Ladies and gentlemen.
This episode is sponsored by Advanced Skills Company, the official agent of JPI Healthcare in Iraq. I personally use the products of JPI Healthcare in my clinic for years now, and throughout the years, these products have been amazing in terms of providing excellent image quality at the lowest radiation dose possible, and they are durable, reliable, and efficient. I recommend if you are looking to establish your radiology practice, whether in a clinic, in a center, or in a hospital setting, to go to the JPI Healthcare website, see their products for yourself, and then call Advanced Skills Company if you are in Iraq, and these guys will provide the best possible solutions, whether in terms of hardware or software. I will leave the contact information in the video description, and don't forget to use the magic word highlights in radiology, because you will get a 10% discount on all JPI Healthcare products till the end of 2024. Hello everyone, and welcome to a new episode of Highlights in Radiology. Before we start this episode, I just want to remind you to subscribe, like, share, and tell your friends about us. This is Dr. Ahmed Diya Abdul Wahab, and this is Highlights in Radiology Season 2. Stay with me. In today's episode, we are going to talk about pigmented villonodular synovitis, also known as PVNS. Other names for this condition include giant cell tumor of the tendon sheath, and also sometimes we call it benign synovioma. It's a group of benign lesions that arise from the synovium. So it can be found in a joint, bursa, or tendon sheath. The difference between the giant cell tumor of the tendon sheath and the pigmented villonodular synovitis is that giant cell tumor of the tendon sheath is a localized form and it's extra-articular, while PVNS it's a diffuse form and it's intra-articular. Clinically, the most common presentation of PVNS is limited joint mobility. It might cause increased skin temperature and pain increased with motion and improved by rest. Sometimes might present as a sudden increase of pain due to torsion of a synovial nodule, and if aspiration of the joint fluid is performed, there will be rapid reaccumulation of the joint fluid. While giant cell tumor of the tendon sheath presents with a slowly enlarging mobile soft tissue nodule that is associated with pain increased with activity. Giant cell tumor of the tendon sheath ranges from 2 to 4 centimeters, while PVNS usually is large and irregular in shape. Both giant cell tumor of the tendon sheath and PVNS usually presents around 30 to 50 years of age patients with equal male to female ratio, while PVNS has more predilection for females. The giant cell tumor of the tendon sheath are commonly seen in the hand and wrist, especially the volar aspect of the digits. Also, it's seen less commonly in the foot and ankle, usually the first or second toes. Usually they are solitary lesions and might cause some pressure erosions. And they might show calcifications, which can mimic synovial chondromatosis or calcific tendonitis, while PVNS is seen most commonly in the knee and less commonly in the hip, ankle, shoulder, or elbow joints, and are usually monoarticular. This mass usually has an irregular frond shape. Up to 50% are associated with bony erosions, most commonly in the hip, in addition to subchondral cysts on both sides of the joint. Also, they cause joint effusion. A very important clue here is that the joint space is preserved. In chronic conditions, the joint space will narrow and we will see some osteophytes. PVNS is a benign, locally aggressive lesion with 20 to 50% recurrence rate. So the best treatment is total joint replacement. So regarding radiology, what do we have to offer? Giant cell tumor of the tendon sheath will be a mass adjacent to a tendon, while PVNS will appear as a heterogeneous, well-defined synovial-based mass. Like we see here in this X-ray. This is an X-ray of the finger showing a soft tissue nodule at a location corresponding to a tendon, indicating most probably this is a giant cell tumor of the tendon sheath. Another example of this knee X-ray, you can see the big soft tissue mass, irregular, frond-like, and this turned out to be pigmented villonodular synovitis. On the CT scan, we will see the soft tissue mass with erosions that are sharply defined, with sclerosis of the margins. This mass will appear dense relative to the muscle, not because it contains calcium, but because it contains hemosiderin, and it will show post-contrast enhancement with joint effusion. While on MRI, giant cell tumor of the tendon sheath will show low signal intensity on T1 and heterogeneous signal intensity on T2 weighted images with intense post-contrast enhancement. Like we see here on this MRI. This is a T1 weighted image, and you can see the mass, which is giant cell tumor of the tendon sheath, will show on T1 weighted images low signal intensity. It's more on the iso to low part of the signal intensity, while on T2 weighted images, you can see the mass that appears heterogeneously hyperintense, as we said. On the axial post-contrast enhancement images, you can see the mass is heterogeneously enhancing. Another example, this is an MRI of the finger showing a mass that is related to the tendon, and it appears iso to hypointense on T1 weighted images and hyperintense on T2 weighted images with intense post-contrast enhancement. On the other hand, MRI of pigmented villonodular synovitis, on T1 weighted images, we will see a hypo or iso-intense mass with foci of high signal intensity, which represents lipid-laden macrophages. For example, if you look at this image of T1 weighted MRI of the knee, you can see the big irregular frond-like mass that is hypo-intense on T1 weighted images with foci of hyperintensity representing lipid-laden macrophages. Another example here, and we can see the same thing, the big mass hypointense on T1 with erosions of the adjacent bone. On T2 weighted images, it will show iso or hypointense signal with areas of hyperintensity with intense post-contrast enhancement. For example, in this MRI of the knee, if you look at the T2 weighted images, you can see there are multiple foci of low signal intensity within a big mass surrounding the knee joint. Another example here, you can see this big mass that appears hyperintense with areas of low signal intensity, which corresponds to the hemosiderin within the mass. And on this image, you can see that this mass will show intense post-contrast enhancement. The mass of PVNS will show septations, and they tend to extend away from the joint, and they show low signal on all pulse sequences because they contain hemosiderin. So what about the differential diagnosis? We have a good list that includes synovial sarcoma, synovial chondromatosis, hemophilia, rheumatoid arthritis, synovitis, and lipoma arborescens. Synovial sarcoma arises outside the joint, and it's called synovial, but it's outside the joint. It contains areas of calcification, and it appears more hypointense on T1 and more hyperintense on T2 weighted images than pigmented villonodular synovitis. Like, for example, if you look at these images, you can see there is a big mass that is outside the joint. It appears hypointense on T1 and hyperintense on T2 weighted images, and it shows intense post-contrast enhancement. Another example in this new MRI showing a mass away from the joint, outside the joint, and it shows intense post-contrast enhancement. Another example on this X-ray, you can see in the hip joint there is a lesion that shows areas of increased density due to scattered calcific foci. Again, on this CT scan, you can see the lesion containing foci of calcification, and it shows heterogeneous post-contrast enhancement, but it's outside the joint. Now, regarding synovial chondromatosis, it shows multiple intra-articular loose bodies which can be calcified or non-calcified. For example, if you look at this CT scan, you can see multiple intra-articular loose bodies that are calcified. And on this MRI, you will see innumerable intra-articular loose bodies that show low signal intensities, suggesting possible calcifications of these loose bodies. Hemophilia affects multiple joints and can cause growth disturbances. For example, in this MRI of a patient with non-hemophilia and hemophilic erythropathy, you can see the synovium is thickened with hypointense signal due to hemosiderin deposition from the recurrent bleeding into the synovium. Another example, in this elbow MRI, you can see the synovium is thickened with very hypointense T2 signal due to extensive hemosiderin deposition from the recurrent bleeding into the joint. Rheumatoid arthritis show no hemosiderin deposits. It causes joint space narrowing with periarticular osteoporosis, while PVNS, the joint space is preserved, and the bone mineralization with joint space narrowing seen only in chronic stage of PVNS. Like for example, in this X-ray of the knee joint, you can see the joint space narrowing and the periarticular osteopenia, suggesting rheumatoid arthritis rather than PVNS. Another example, this knee X-ray, you can see the marked joint space narrowing with periarticular osteoporosis or osteopenia. Synovitis is an inflammation, so by default it has a high signal intensity on T2 weighted images, so it appears hyperintense on T2 weighted images. For example, in this MRI, you can see the synovium is inflamed and it shows high signal intensity on T2 weighted images. Regarding lipoma arborescens, it will show signal intensity of fat on all pulse sequences because it's just a lipoma. Like for example, in this T1 weighted image, you can see that the lipoma shows high signal intensity equal to that of the fat. And on this T2 weighted fat saturated image, you can see complete loss of signal in this lipoma arborescens. Another example, in this T1 weighted MRI, you can see the lipoma arborescens following the signal intensity of the adjacent fat. At the end, don't forget to subscribe, like, share, and tell your friends about us. If you have any comments, write them in the comment section. See you next Friday at 5 p.m. This is Dr. Ahmed Dia Abdul Wahab, and this is Highlights in Radiology Season 2. Bye.